Now it's my pleasure to present Professor Mick Kumwenda from UK. He works as consultant nephrologist and clinical director in Renal and Diabetes Center, Glenclwyd Hospital in United Kingdom. His research interests include diabetic kidney disease, progression of CKD, cognitive dysfunction, the role of the kidney in glucose metabolism and management of end-stage kidney disease in people with diabetes. And today, he will present us the diabetic dyslipidemia. Thank you, Professor Kumwenda.
Good morning. Thank you very much, Professor Shenas. Great to see you again. I'm going to talk about, I'll split the talk into these subheadings. What is the good, the bad, and the ugly side of lipids? What are the trends in outcomes in the challenges in cardiovascular disease and diabetes? In tackling the pandemic in a clinical setting, what do we actually focus on in lipid management? And then a brief discussion on and what the guidelines are telling us what we should be doing in looking after these patients. And of course, we need to also touch on beyond life modification and starting therapy for dyslipidemia in diabetes. So the good side of lipids, actually, they are very important for function of cell structure. Lipids are biological molecules such as fats, oils, phospholipids, and steroids. They're important for cell membranes, energy storage, insulation, and cell-to-cell communication. And cholesterol is an important lipid found in cell membranes. All these 5 major classes listed here. And of course, we have to know about the triglycerides as a very important component of lipid, particularly found in dietary fat and fat deposits of animals. So a vast range of important functions of lipids as a family, which we could spend the whole morning discussing, but that was not the idea. It was just to remind you the basic sciences from time we were in university. And the bad side of lipids, when it's associated with diabetes, and we all know the scale of the problem with the prevalence of diabetes, and this is a global report from WHO published in 2016, looking at the prevalence of diabetes in 1990 and predicting what would happen in 2014. And of course, that is, in reality, has happened. There's been a doubling of the prevalence of diabetes in these regions, affecting others more than certain others more than elsewhere, particularly Eastern Mediterranean region. And the actual number of patients suffering with diabetes has also fourfold increased from 108 to 422 million in 2014. So the ugly side is when you got hyperlipidemia and you got diabetes, what would be the problem? The problem, of course, that we focus on cardiovascular risk factors. And these are a range of studies that have been published in a systematic review in 2008. 30% of patients with type 2 diabetes have some form of cardiovascular disease, and cardiovascular disease is a major cause of mortality in type 2 diabetes. So all these things you're well aware, but I thought we should just start off by putting that into concept. It's not all doom and gloom, and this is again published in the WHO report that I've mentioned earlier. These are the trends of all-cause mortality, not cardiovascular mortality, but all-cause mortality among people with diabetes by country between 1988 and 1915. So good news is that all the proportions have gone down from 1990 to 2019 in most countries. The bad thing is there are some countries that they were pretty bad, in the frequency of all-cause mortality. And this is, you can see Finland at the top there. But again, there's a very steep slope reduction in the mortality rate in Finland. So they have done something about it. And then there are some incredible lower rates compared to others like Sweden. Right at the bottom of the graph there, you can see that in fact, as far back as 1999, Sweden were doing pretty well in the lowest mortality rate within type 2 diabetes in the world. So there is something, some people are doing well, and we all need to do something. We need to work harder to achieve more reduction in mortality rate in diabetes. And one way to do that is to actually aggressively tackle the modifiable risk factors. And for today, this morning, we're going to discuss dyslipidemia and diabetes. But of course, we shouldn't forget that we also have, at the same time, it's not just bringing the cholesterol down that is important. You also have to tackle smoking, blood pressure control, obesity, dietary factors, and lack of exercise and excess alcohol consumption. And unfortunately, there are some non-modifiable risk factors that actually are dominant contribution to this mortality rate. And that is, these are personal genetic factors, family history, and age. We can't do anything about that. Gender, we can't do anything about that. Even if we try and change gender, it still does not change your genetic cardiovascular risk factor that you may still have. So although we are talking about lipids, in isolation, the achievement of mortality reduction is very low, but as a group of modifiable risk factors and aggressive therapy in those patients at risk, then we will see those trends I've shown you earlier. Tools that we've got that we can achieve to do so. And lifestyle modification, very easy for us to say. Lifestyle modification, very difficult really to make a difference, and particularly also to sustain that difference that patients have tried to do. Optimizing a glycemic control, I think we are very successful at doing this, and the number of agents to help us. Even within insulin, there's lots of short-acting, medium-acting, long-acting, and there's now all these other drugs, the SGLT2 inhibitors and incretins, giving us more weapons to reduce mortality in our patients. And optimization of blood pressure control is already well known to yourselves. And any patients who is showing any sign of renal damage with microalbuminuria or macroalbuminuria, again, aggressive therapy treatment with angiotensin II receptor antagonists or ACE inhibitors. So how is the lipoprotein spread within type 2 diabetes? You can see high triglycerides, VDL cholesterol, remnant intermediate density lipoprotein cholesterol, reduction in HDL-C and apoprotein A, increase in LPA, and sometimes variable, predominantly increase in LDL cholesterol. And we don't measure these lipoproteins in clinical practice. I wouldn't worry about that. You can do, but of course they are expensive to measure. I'm just showing you that actually measuring cholesterol will do in most patients, and you can see the correlation between ApoB and cholesterol here, showing that actually if you control cholesterol, you're more likely also to bring ApoB down. So, I wouldn't worry too much if we are not able to monitor lipoproteins in clinical practice. So, life modification, yes, very important. You can see what we can achieve in lipid reduction. So, weight reduction itself will, achieve reduction in LDL, a drop of 10 kilograms in weight, you'll see 5% reduction in LDL, 10% in triglycerides. And if we adopt a specific DASH, for instance, you see a drop in cholesterol, 5%. Carbohydrate reducing intake, again, you can see there 10% reduction triglycerides and 10% reduction in triglycerides, and that should be actually, that arrow should be going up, 5 to 10% increase in HDL cholesterol. And physical activity, you know, easy for us to say, very difficult for most patients to sustain, but nevertheless, the message has to go there that you can make a significant reduction in these lipids in these patients. Moderate alcohol intake may not be relevant in some regions, but certainly in the West, this is an issue that we need to tackle. So modest reduction in lipids in our patients, and therefore we have to resort to drug therapies. And cholesterol is one that we can easily bring down with statins. And I take you back to this study, multiple risk factor intervention study, that was started in 1972, as you recall, in the United States, correlating adjusted cardiovascular death between controls and type 2 diabetes, depending on the level of cholesterol. As the cholesterol goes up, then the cardiovascular risk actually increases much more in type 2 diabetes than control. So we've known this since 1992. We are in the right direction, but I think we could do better. And again, if we use statins, you can see this dramatic improvement in cardiovascular event reduction. And this is a study, a meta-analysis of 14 randomized control studies showing that the benefit of lipid management with statins in diabetes is actually quite dramatic. So the question is, if the patient hasn't had a cardiovascular event, should we also be giving them statins? And I show you these primary prevention trials in lipid-lowering agents using statins in type 2 diabetes. And you can see that actually most of the studies did not show much benefit, except the heart protection study that was done in the UK using simvastatin. There was a statistical significance high cholesterol, and you're struggling with diet management, then you can't give statin. So what do I do personally if I have a diabetic and we are not getting very far with lifestyle modification and they have a high cholesterol? I tend to add a statin. But secondly, in secondary prevention, then pretty much all the studies have shown benefit, and therefore if there has been a cardiovascular event, it is absolutely mandatory that these patients must also go on a statin. Triglycerides, again, here's data to show that we should be tackling triglycerides, and statins will bring triglycerides down, but you may also have to consider fibrates to be more effective in bringing triglycerides down. So you can see here, or again, all-cause mortality, if we are treating patients with hypertriglyceridemia, they can see that there is benefit for those quartiles over 150 milligrams per deciliter. I just wanted to bring nystatin in the discussion because, I mean, this is not a very popular agent for our patients, particularly because of side effects. And one really bad side effect that they do report is flushing. And it can be distressing in some patients. But, you know, nystatin, as shown in this study published 2016, you can see that giving nystatin increased HDL 10 to 35%, which is very good, and apoprotein reduction, you can look at the triglycerides, 20 to 30% reduction, LDL cholesterol, 10 to 25%. So this would be additional if the patient is on statin. But look at LPA. Statins are not very good at bringing LPA down. So that is 20 to 30% reduction. So if you go patients with high risk of cardiovascular disease, then perhaps small doses to start with and slowly increasing the dose over time will be a good idea. So very effective agent in addition to statin. And sometimes you may have to combine, of course, a statin, fibrate, and then throw in nystatin if patients are struggling to get the cholesterol down. But like I said before, the actual very important factor is to combine management of all these risk factors and treat aggressively those patients who are at risk cardiovascular disease. And last study I need to show you is this that you know about. This is the Steno study that looked at split patients with aggressive management of all risk factors and anti-lipids medication. Studied the patients over 8 years, and you can see the risk reduction for progression of cardiovascular mortality, morbidity, as well as renal impairment and retinopathy. Risk reduction was dramatic in the patients who had statins and angiotensin receptor antagonists and ACE inhibitors. And you can see the graph there showing a split of benefit intervention versus conventional usual care, dramatic improvement in multiple risk factor management in patients at risk. But when we then looked at this study more carefully, and this was published in 2014, to see which components actually made a major contribution in the reduction of risk factor for these patients. And you could see HbA1c, the patients that achieved targets 13%, 11% systolic blood pressure. We managed to reduce smoking 3%, but you can see the dramatic impact was that pretty much all the patients who had high cholesterol, these came into target. And there was a discussion in the paper to say, in their view, it was the lipid management that made a big difference to the group of patients that had benefit from multiple risk factors management. So here are the guidelines, and I won't spend too much time on the guidelines, which you already know. These are ADA guidelines. So basically, most other patients with diabetes measure fasting cholesterol and then treat to target and monitor over time as well. And again, patients with high triglycerides, you've got levels here that we should be aspiring to get to, and monitor over time. So lifestyle modification, treat to target, and then monitor every so often, either in the clinic or pass it on to the general practitioner in primary care, like we do in the UK, to do so. It's very easy to do. Lipid management, personally, I think is one of the easiest risk factors to treat. So these are the numbers needed to treat statins for 5 years. You will save lives quite easy compared to number needed to treat to save one life. So 100 patients for 5 years, you save one life. Compared to antihypertensives, compared to aspirin, you need 300 to treat 333 patients. But again, like I said to you before, we've got these other oral hypoglycemic agents who are making a very significant reduction in cardiovascular risk factors. So empagliflozin for 3 years, you need 98 patients to save one life. So beyond statin, I will not dwell too much with this because these are very expensive therapies, pretty much in research centers. So, this is inhibiting PCSK9, which is a pro-protein produced hepatocyte that binds to LDL receptor and therefore reduces cholesterol cholesterol circulation as well as cholesterol retention. And you can see, Ali, in the trial using this agent that is a PSSK inhibitor, alirocumab versus placebo, you can see the level of LDL cholesterol reduction there was pretty much impressive. And so the role for these PCSK inhibitors is those very high-risk patients. They tend to be familial hyperlipidemia, and I've got a familial lipidemia patient who is also diabetic. I haven't actually used this drug, so I haven't got personal experience, but nevertheless, it's something that we are considering. But you can see how the impact on lipid parameters, ApoB 32 to 53% reduction, non-HDL cholesterol 52%, LPL 17-39%, and then lipids, triglycerides 6 to 26%, and so on. So in conclusion, this dyslipidemia in diabetes is something that we can do something about quite easily. We got the tools to do so. Lifestyle modification is one, but certainly treatment with statins, fibrates, and nystatin is something that we've got that we can treat our patients. Statins decrease LDL cholesterol dose-dependent function between 20 and 55%, and we should be monitoring statins for looking for adverse effects, particularly the liver. I'm sure will be of some interest, having heard the last speaker. So I stop there, Chairperson, and many thanks for your attention. Thank you.